Are you tired of struggling to keep up with the daily tasks of running your nephrology medical practice? Can your practice benefit from the added expertise and experience of a team of professionals that are not only knowledgeable in their given field, but know nephrology like no other in the industry? Well, then stay tuned right here for our online podcast, Nephrology Today. Welcome to Nephrology Today, the podcast that brings you the latest insights, research, and expert perspectives in the world of kidney care. I'm your host, Michelle, and today we're talking with Dr. Casey Gashti, a board-certified nephrologist with NANI and an associate professor at Rush University Medical Center. He specializes in helping patients manage kidney disease, kidney injury, transplant care, and high blood pressure with a focus on listening and tailoring treatment to each person's needs. After completing his medical training at Indiana University and advanced training at Rush University, Dr. Gashti has dedicated his career to providing compassionate, comprehensive kidney disease in hospitals, dialysis centers, and community settings. Dr. Gashti, welcome to the podcast. We're so happy you're able to join us.
Thank you for having me.
Nephrology is one of those specialties that doesn't always get the spotlight, but it's absolutely vital. And for many residents, it can feel intimidating or even overwhelming. I'd love to start with your personal story and what drew you to the specialty.
Well, Michelle, my parents were both physicians. Specifically, my father was a nephrologist. So they would talk about medicine at dinner table when I was growing up. And so I've heard of creatinine and dialysis for as long as I can remember. But when I was going through my career choices, I tried to be really open about other fields such as surgery or medical subspecialties. But it always seemed like nephrology was my calling. My job has a very nice balance of acuity and chronicity. I work on the inpatient side, on the outpatient side. So it provides me with quite a bit of variety on a day-to-day basis, which makes it exciting. I'm also an educator, so I interact with residents and fellows and students, both medical and PA students. And so it keeps me on my toes. It forces me to stay up to date on the information, not only on the science, but on how to teach. Teaching has evolved over time from textbooks and articles into online resources and videos and visual learning. So overall, it has been a very nice journey for me, and this balance has made my day-to-day work very fulfilling and exciting. The field of nephrology itself has also come a long way. There is focus now on transplantation, on onconephrology, on interventional nephrology, glomerular diseases. So there have been also a recent emergence of therapeutics, a lot of new agents coming to the market. So it's an exciting time for nephrology.
That's fascinating. I think sometimes people forget that choosing a specialty is as much about personality and curiosity as it is about medicine. But I've also heard residents say nephrology feels like this impossible puzzle. From your experience, what are the biggest misconceptions about the field?
I hear from residents and sometimes students that the field is overly abstract, math heavy, a lot of numbers and acid base. But when it's taught well, I feel that nephrology is really a story of like physiology in motion. There's a misconception that nephrology lacks procedural excitement or any definitive interventions. But if on a day-to-day basis, the decisions around dialysis, transplantation, conservative management, these are among the most impactful decisions for a patient's life. They're very important, and we as nephrologists don't take them lightly. There's also a misconception surrounding financial standpoint, where house staff are now more than ever really care about the work-life balance and compensation versus workload, and that has also been weighing on residents' mind from their interest in applications for fellowship. So as a nephrologist, I find my job very gratifying and fulfilling because of the impact on individuals' life. And as I said before, the balance of work and life is really what you make of it. For me, that's been quite fulfilling and quite balanced. I try to talk to my house staff about that. And when you tell them your personal stories, I think that really hits home. That really tells them that, yes, these are the misconceptions out there, but here's a person that has been doing this for 18 years and he's doing it in a balanced way and he looks happy doing it.
I'm sure they love to hear that perspective. And I imagine part of the challenge is not just explaining the science, but also showing how it matters for real patients. How do you balance evidence-based guidelines with the very individual needs of patients, especially around dialysis decisions?
Yeah, so evidence is, to me, is more of a compass. It's not really a script. Every individual is different. So in dialysis decisions, especially with elderly or frail patients, the data really doesn't give a definitive answer. So I lean more towards what we call shared decision making, using evidence to inform us as to what can be done, but not to dictate what we should do. So this means integrating some of these prognostic models with personal values. I ask my patients, what are your goals? What does quality of life mean for you? When they answer those questions, that not only informs me on how to proceed, but it also makes the patient think about those issues themselves, which then we can input that into what I call the shared decision making with the patient. And that's where sort of the philosophy and the ethics really come to enrich the practice.
Let's talk about your role as educator and mentor. You've trained so many residents over the years, and clearly your teaching philosophy plays a big role in how you practice. What guiding principles shape your approach to teaching?
So, Michelle, I was in undergrad in college. I was a chemistry and religion/philosophy double major. So, those are very different fields, sort of almost at the very two ends of the spectrum of objectivity and subjectivity. So, I use both of those, both the science and the philosophical part of my training to inform my day-to-day education and work. So, I believe, as part of teaching, in constructive discomfort, that to challenge the residents just slightly beyond their comfort zone. But I also, want to provide a net of support for them. I want to make sure that teaching the residents that uncertainty is okay. It's not a weakness. It's a core component of medical reasoning. And I value mentorship as such. I believe that a good mentor, a good educator, should have a relation with their trainee as opposed to a transactional relationship. So it's really more about a mutual growth over time. Letting the resident and the fellows see that you can be vulnerable, that you can be uncomfortable, and those are okay, and those are normal parts of learning is one of the keys to making them feel comfortable and open their mind to what I want to teach them eventually.
Yeah, I love that. It's about teaching them how to think, not just what to think. I'm curious,
Right.
is there a moment or story that really shaped your approach?
Yeah, I do remember a resident once approached me months after a rotation saying that what stuck with her wasn't really a lecture or a handout, but a conversation we had about the emotional weight of medicine and how much it sort of has taken such a big role in our lives. And it reminded me that really sometimes mentorship isn't just about teaching people clinical pearls. It's really, that vulnerability, that balance and purpose is important. So that moment, I kind of changed how I show up, not just as a teacher, but as a person. The small talks that I have with my house staff, the social conversations, the humor on rounds, they all kind of all tie into building that relationship of trust and then admiration. And that sort of, again, opens minds to learning the science. I'm also learning from them. This is a two-way street. Education is sort of an ever-evolving field, and I am constantly learning new things from my residents. The old ways of teaching has sort of been dated. And I'm learning more and more that residents learn from social medias, from online resources. And so I have to adapt as an educator to their level of learning. And to me, that is very impactful, just to connect with them at their level.
I'm Michelle, and we're listening to Dr. Gashti give his perspective on teaching and mentoring fellows in a nephrology setting. Dr. Gashti, that's powerful. It seems like teaching in medicine is never just about the facts, but also modeling values. And you touched on You touched on the humanistic approach to your teaching methodology. What advice would you give to educators who want to bring in that more reflective humanistic dimension?
Well, I would say that remembering that clinical medicine is story driven, the patients usually bring their narrative of illness, but clinicians are tasked with, constructing the narratives of care. I would share moments with my uh, patients and with my trainees of my own inner conflict, not necessarily to confess, but to show them that these decisions that you have to make are big decisions. They're complex. They're often uncertain, and it's okay to feel that way. Showing vulnerability and humility to both patients and educators is something that I feel like would make people connect with you. And I admit when a case challenges me, both intellectually or emotionally or ethically. So I have had many conversations with my patients, especially when my patients are older and they may or may not be able to make all of their own decisions and the family members are involved. I usually uh, speak out loud about how I feel, but I would also say, but I feel that if this was my mom, I would do this. But everybody's different. Everybody has a different idea of quality of life. And so you have to consider what I'm saying as a sort of as a framework. But ultimately, like I said before, shared decision making is important. And for educators, it's very important not to come across as a rigid, only fact-based approach to medicine because human beings are not constructed that way. We are full of emotions and data will guide us, but at the end of the day, I think these decisions are too complex to be left to just data.
So, speaking of ethics, this is an area where nephrology is so distinct. You're often right at the intersection of medicine values and very personal patient decisions. How do you help residents develop those skills to have these conversations with patients?
Well, I use in my sort of, philosophical background, I always encourage my residents to listen. Listening is very important. We sometimes have a tendency to speak most of our visits, but listening is sometimes even more important than speaking. Sometimes the patient needs somebody to just, have a conversation with, like, a little mini therapy during your visits would be very helpful. So I always try to endorse to my residents that listen to your patients, and in the process of listening, they will tell you things about themselves that will guide your treatment as well. They will tell you that they took such and such medication, or they, have a family history of their parents were on dialysis, or something that will inform your clinical decision as well. So listening is one of the under-recognized aspects of medicine where some people don't do a good job and some people who are really good at what they do listen very well. So I emphasize that quite frequently to my residents.
That's such a crucial skill. And I imagine it's not just about teaching, but also about supporting physicians themselves. What role should the humanities play in medical education today?
I feel like a central one. Humanities really train us to interpret meaning, recognize that the decisions that we make are complex, and to sit with uncertainty, all essential skills for a clinician, right? We have to interpret, we have to recognize complexity, and we have to be okay with uncertainty. So they help us care not just for the patients, but with them. And that triad of recognition, I feel that humanities can teach you. Philosophical approaches of questioning frameworks is also very relevant in science, and I think that you can marry the two in your day-to-day interactions with patients and with your residents.
That's great. And as we wrap, I want to shift from the professional to the personal because it's clear you've built a career that bridges science and philosophy in a really rare way. And finally, what advice would you give to young doctors who want to pursue both clinical excellence and humanistic inquiry?
One of the observations that I've had in following the house staff from their medical school, even pre-medical school to medical school to residency to fellowship, is that sometimes that sense of empathy and curiosity fades. And so, what I want to keep stimulated and alive is to protect that sense of curiosity. That intellectual curiosity is really what drives you for the rest of your life. Otherwise, you will be bored with your career. And so, I advise them to seek mentors who have value both sides of your identity and don't let sort of the curriculum of medicine convince you that speed or certainty is always the best thing. I ask them to carve out some time, maybe even 30 minutes a week, to reflect on why they're doing what they're doing, to read or write down their feelings about it, and it will nourish your practice in ways you can't really predict. Is reflection is something that we also don't do as well or as much. So yeah, so protect your curiosity, reflect, question, sort of be intellectually curious about people and about their disease state.
I love that approach. Well, this has been such a rich and thoughtful conversation. Thank you for showing us not just the complexity of nephrology, but also the wisdom and humanity behind it. Do you have
Thank
anything
you.
else that you would like to add, Dr. Gashti?
No, thank you for having me. I feel very honored and glad that I am part of this group, NANI, Nephrology Associates of Northern Illinois, because they're supporting this podcast in a way that they are essentially bringing the physicians into the spotlight, because physicians usually are looked at as, they are scientists. But what is missed is that we are scientists, yes, but we also have to deal with very difficult human decisions that are not scientific. There is no scientific or data-driven framework for it, and the humanities really brings that angle to how we have to or how we should be making some of these life and death decisions. And I am glad that NANI has bringing this into a spotlight, that physicians are philosophers, educators, as well as scientists.
And thank you for speaking on your approach to teaching. I think it's so important for new fellows to hear that. For more information, please visit nephdocs.com and be sure to listen to our podcast on Spotify or wherever you get your podcasts. Again, thank you to Dr. Gashti for joining us today.
Thanks, Michelle.
Thank you for listening to Nephrology Today. We hope you tune in again real soon.